Today, yesterday we went over oral pharynx. Today we'll be doing larynx part 1 and part 2. Any questions on the material that we covered so far? No? Okay. All right, we'll get right into it. This is our course terminal objective. Oh yeah, one side note though, from the information that we covered yesterday, just so you all understand, the modified Centaur score or the Centaur score, you have to memorize that. That's not going to be like given to you on a text. So I just wanted you guys to know like it won't be available to you, but that's something that you have to memorize and apply to questions. All right, these are our enabling learning objectives. And then let's get into a little bit of anatomy and review just so we understand some of the disease processes that we'll go over. So just of note, taking a look at the epiglottis, the pharynx, the larynx, the trachea, the relationship of the esophagus to the larynx, right? So that opening, because we'll talk about laryngeo-pharyngeal reflux. And then looking at the vocal cords, so that visual is looking down with the laryngoscopy, looking down onto the vocal cords. So a lot of these disease processes, we won't be able to evaluate because we can't see the larynx. The larynx is where the pathology is. So in order to do that, we have to get a laryngoscopy. Some of the clinical diagnoses, some will be clinical diagnoses. So just kind of keep that in mind as we're going through this. But then you can see I'm looking down in the trachea, the vocal cords, the tongue, etc. All right, just really quick going over the functionality of the vocal cord. So it's protective, it allows air to move through. It has some nerve innervation and some muscle innervation. So vagus nerve 10 innervates the larynx, and then it has two branch nerves. That's the recurrent nerve and the laryngeal nerve. So both of those are branches of vagus nerve 10. And then voice production, so that's phonation. That's just me actually speaking. That's just you listening and speaking. Those vocal cords are brought together. If they're more taut, that's when phonation occurs, so sound is able to be produced. If they don't come together, then that's when you start to have abnormalities, hoarseness, breathy voice sounds, stridor, that kind of thing. And then again, this is just a good picture of you looking at the vocal cords when they open normally, and then when they're closed, they should close and touch in its entirety. So the primary symptom of laryngeal disease is dysphonia or abnormal speech. So this can manifest in different ways. Like I talked about, you might have a high pitch, more of a low baritone pitch. Patients might have that hoarseness. So we'll talk about how those sounds manifest with different disease processes. For example, unilateral vocal cord paralysis. I'll show you a picture, but if the vocal cords are not coming together like in that previous picture, air is coming through the trachea. So when they speak, it's like a breathy sound because air should not be coming through. Well, it's not that it shouldn't be coming through. More air than normal is coming through when you speak. So when it should be closed, air is flowing through. That's causing that breathy sound, or somebody feeling like they're out of that exact shortness of breath or exacerbation. For harshness, so think about the disease process is at the vocal cords. If it's inflamed, so it could be edematous, it could be damaged as far as like the epithelial, because it's still skin there, it's cartilage is skin right there. So that could be happening. It could be malignancy. So if they have a bump, if they have some ulcer that's located on the vocal cord, that could be occurring there as well. And then going into stridor, so this is still a type of dysphonia or abnormal phonation. So that's where they have a high-pitched sound. So inspiratory, when I'm breathing in, that's when you know that the sound is above, the narrowness is above the vocal cord, versus expiratory, stridor is when I'm breathing out. So the sound is occurring when I'm breathing out because the air is coming out. Biphasic, it can be when a person is breathing in or out, but usually it's going to be when the patient is breathing in. and the location will be below the vocal cords. Evaluation. So in general, when we go through these, you'll see like hoarseness is the most common symptom. Again, we cannot see the larynx unless we do a laryngoscopy or if the patient presents with other manifestations that clue us in on medical emergencies. We want to get a good HPI, social history. Have they been smoking? Do they drink? Do they use vape? Do they drink alcohol? Have they had any past medical history of malignancy? All of those things take account when developing our differential. And just of note, all cases of stridor need to be referred to ENT because we can guarantee it's some type of narrowing somewhere in the larynx. And then hoarseness, we usually wait for about 2 weeks or a little bit more because it can resolve. Like if it's acute laryngitis, then it might resolve, so there's no need to refer them out. So these are our common laryngeal disorders: acute laryngitis, laryngopharyngeal reflux, that recurrent respiratory papillomatosis, and then epiglottitis. Simply, acute laryngitis is inflammation of the larynx for less than 2 weeks. So just kind of remember that time frame. We're in the less than 2 week window. It can be caused by viruses, by bacteria. Those are the two most common causes. Patients can have associated upper respiratory tract infection symptoms, so that nasal pain, fever, fatigue, congestion, phlegm, feeling like something is stuck in the back of their throat, or like if they want to cough up something, that lymphadenopathy as well. And then of course they may have hoarseness. It can last beyond a week. That's why we usually say that 2 week window is the cutoff for acute laryngitis. This is a good example of normal larynx looking down. We're doing an endoscopy where we're looking down into the larynx. You can see here the vocal cords or folds. So those are synonymous things by vocal cord, but vocal folds here. This is all normal, but then if you go on the right side, you can kind of see it's swollen. Even the vocal folds are swollen here, a little bit of abnormal color. Just an example so you can have a visual. So the first line treatment for acute laryngitis is vocal rest. We can add symptomatic treatment if they're having other upper respiratory tract symptoms. So like those saltwater gargles, analgesics, NSAIDs, etc. But the first line treatment is going to be vocal rest. Humidification will just help kind of soothe the larynx, but first line treatment, vocal rest. No singing, no shouting, no going to games, football games, screaming, that kind of stuff. All right, now before we get into laryngopharyngeal reflux, you kind of have to understand a little bit about GERD. Has anybody ever heard of GERD or know somebody with GERD? It's fairly common. So just understanding the pathophys where that lower esophageal sphincter is loosened and some of the gastric content is coming up into the esophagus, right? So that's just like the pathophys. So they're having those symptoms primarily associated with eating or it could be positional, right? But it's affecting that esophageal lining where they could have irritation or even develop peptic ulcers. Then going into, like I said, the symptoms, they may have belching, regurgitation, but so understanding that pathophys to get into the laryngopharyngeal reflux. So the gastric contents by way of the esophagus, they pass the larynx into the oropharynx, and some of that gastric content enters into the larynx. So and that's a good picture where you can see the relationship between the esophagus and the larynx. So ideally, patients with laryngopharyngeal reflux, they've had a past medical history of GERD, chronic GERD, I'm talking about for years, or they're extremely obese. Other risk factors, smoking, alcohol, diet, medications, anything that's going to increase the intra-abdominal pressure, that is a risk factor for laryngopharyngeal reflux. So how we can differentiate these in clinic at least, symptoms, so if the patient these symptoms will occur whether the patient is laying down or sitting up. It's not positional like GERD. And then also that chronic hoarseness greater than 4 weeks, that chronic cough, chronic throat irritation, all of those differentiate laryngeal pharyngeal reflux from GERD. For a physical exam, we might not see much besides throat irritation, so some erythema. Again, we can't see the larynx, so we have to refer them out to get a laryngoscopy for a definitive diagnosis. After they get their laryngoscopy, they have a definitive diagnosis of laryngeal pharyngeal reflux, then we can treat them with a PPI. And essentially, it's the same treatment for GERD, where we're trying to rebalance the acidification of the stomach, those gastric acids. So we do high dose omeprazole for about 3 months and then kind of reevaluate them. So for recurrent respiratory papillomatosis, so this is caused by the HPV, human papilloma virus, 6 and 11 primarily. It can be caused by 16. It's believed to be transmitted. So HPV is a sexual transmitted disease or infection, right? So it's an STI, and it's believed to be transmitted from the genital region into the larynx, the oral pharynx region, by way of multiple processes or from mother baby. Right, but the key here is to understand once the larynx or the oral pharynx has HPV, it is not reversible. So we have to send these patients out. Some symptoms and manifestations, hoarseness, like we talked about, they may have stridor, and then on our laryngoscopy, we can see one papilloma, but then it develops into the recurrent respiratory papillomatosis, and this is not something that they can eradicate. So we will refer them to ENT. They can make the definitive diagnosis, and then they can decide whether they want to observe surgical excision, injections, etc. Complications. So it can spread to the trachea or the lungs. Again, just kind of remembering our anatomy and how close everything is. Malignancy transformation. So if these patients aren't treated accordingly, they can develop malignancy, most commonly squamous cell carcinoma in the larynx, and we'll talk about that. Prevention, it is a HPV vaccine available. Ages, I think it's from 9, and they recently increased the age up to 45. When the vaccine originally came out, it was like up to 21 or 24, but after a lot of research and data being published, I want to say they can do, they recommend that you get the vaccine up to 45 years old. You can still receive it. All right, our first question of the day. Any volunteers?
39-year-old male presents with hoarseness times 4 days. He denies sore throat, pain with swallowing, difficulty breathing, fevers, or chills. He denies tobacco use, alcohol, recent shouting, or voice strain. He reports having a cold recently, which resolved about a week ago. His physical exam is remarkable only for raspy, strain, phonation. He denies allergies. Vital signs are unremarkable. What's the most likely diagnosis for this patient's medical condition?
What are we thinking? Acute laryngitis. We really haven't talked about the other ones, but just kind of giving you a clinical picture. So it's hoarseness, only been going on 4 days, no history of tobacco use, a little bit of sore throat, fever, chills, those upper respiratory tract infection symptoms. So we can kind of narrow it down. Chronic laryngitis, that's going to be over 4 weeks. Epiglottitis, we'll talk about that in the presentation of it. Squamous cell carcinoma, not so much. Tonsillitis, nothing shown on physical exam that even hints us into tonsillitis in this scenario. All right, another volunteer.
39-year-old male that presents with hoarseness times 4 days. He denies sore throat, pain, swallowing, breathing, fever, or chills. He denies tobacco use, alcohol, recent shouting, or voice strain. He reports having a cold recently, which resolved about a week ago. His physical exam is remarkable only for a raspy, strain-sounding voice. No other findings. Vital signs are unremarkable. What is the first-line pharmaceutical treatment for this patient's diagnosis?
take corticosteroids. So I do have vocal rest, but it's not a pharmaceutical treatment. So I could, what I should be asking here is, what is the next best step in management? And then it will be vocal rest. So just understanding, so if you want to kind of make a note, that's fine. But just understanding the actual question needs to be shifted a little bit. That I'm asking you, not the vignette. You guys have farm tomorrow? Or yeah, okay. Yeah, because you guys are like very mellow, kind of like, okay. All right. All right, next, epiglottitis. Oh, yes, sir.
I apologize, I just had a question about the so is there,
Sorry, I just can't hear when I'm.
I apologize, ma'am. So Strider is predominant in children, so it's like 2 to 9 or just about like.
So Strider can occur in adults or children,
Right.
either one,
But it's more common.
but it's more common in children. And we'll talk about some of the disease process as to why. Well, one, infection, and then epiglottitis. We'll talk about that. Is that the, did you have a second half to your question?
I thought I did, and I lost it. So
Okay, and just let me know if you, if it comes back to you. All right, epiglottitis or supraglottitis. I rarely hear it referred to as supraglottitis, so we'll go with epiglottitis. Most common cause is going to be bacterial, that Haemophilus influenza. Understand that is the most common cause, but it is a vaccine available. So we've had significant incidence rate, reduction in incidence rate, but that is still the most common cause. Viral is extremely rare. It can be thermal or caustic, but bacterial will be the most common cause. Patient will present with rapid onset of feverish chills, hoarseness, abnormal tripoding. Like, it will be evident that this patient is not able to breathe. They're having difficulty breathing. For adults specifically, because this more commonly occurs in children, if adults have epiglottitis, they may have diabetes, mainly because, you know, the immune system is weakened with patients with that have diabetes, so that's a risk factor for adults in epiglottitis. So physical exam, this is a good picture of how the patient may present, and it's gonna evolve rapidly, like from 4 hours to 6, definitely within 24 hours. Again, we cannot see at this point, we cannot see the larynx, but we may be able to do an oropharynx physical exam and just put in the clinical picture HPI together along with the physical exam findings. Kids most commonly drooling, dysphagia, and distress. Can't breathe, they may have that stridor, so that high whistling sound when they're trying to talk or when they're crying. Leaning forward, that's that tripod position. Imaging is not necessary, but you can order, and it depends on where you are, your setting, and depends on your practice. You can order an x-ray, it'll confirm that thumbprint sign, and I'll show you an example of that. Definitive diagnosis is gonna be the laryngoscopy, because we can actually see the larynx and the epiglottis, but we don't have time in this scenario to say, hey, let me refer them to ENT to do a laryngoscopy. No, we can't do that. This is just an example. On the left, or under A, you can see the normal epiglottis there, and then on the right, that's a patient that's been intubated, and then the epiglottis. You can see how swollen it becomes and actually blocks the airway. So that's what we want to prevent. This is an example of the thumbprint sign. Like I said, this is a clinical diagnosis. So next step is not to get an x-ray or a laryngoscopy. Next step is to arrange airway management because this progresses so rapidly. Now getting into the treatment, so medical emergency, get control of the airway, and that means arranging for intubation. It could, depending on how the patient is presenting, a nasal cannula or an oropharyngeal airway, depending on your setting. But whatever you do, the first thing is to get control of the airway. And then after that, we're going to start IV antibiotics and then dexamethasone, and we can consult ENT if necessary. If this patient presents to you, real life kind of stepping out of academia. But we need to coordinate with the ER if we're at a battalion aid station. Like, don't just say, hey, go send, just, send them over there. Call them, let them know they're coming so they can prepare, because this progresses really rapidly. All right, stepping back into academia. These are examples of airway management. So that oropharyngeal airway, nasopharyngeal airway, endotracheal intubation, that bag valve mask, something to ensure we have to control the airway. All right, check on learning. I got this picture right today, because this is exactly how it looks right now. All right, question. Any volunteers? Anybody?
A 4-year-old female is brought to the urgent care clinic by his parents due to a sudden onset of high fever, sore throat, and difficulty swallowing. He is drooling and sitting in a tripod position. On physical examination, he appears anxious and is breathing with audible stridor. What is the patient's most likely diagnosis?
Definitely thinking C. What kind of clues you into C? Tripod in position, anxious, unable to breathe, that audible stridor. I think this is our last question. Yeah. One more volunteer. Almost there. Come on.
A 4-year-old female was brought to the urgent care clinic by his parents due to a sudden onset of high fever, sore throat, and difficulty swallowing. He is drooling and sitting in a tripod position. On physical examination, he appears anxious and is breathing with audible stridor. What is the most appropriate immediate action to manage this patient's care?
Yes, A. Airway management. All right, let's take a break. We'll do like 5 minutes, so 1:27, and then we'll do part 2 of forbearance.
Coding the lining. You know what's most likely used for? Who uses it? Yeah, but who's the most likely? Who's on the slide? Who's on the slide? Who? Picture baby, Can we be in the morning? Curious, yeah.
You want to know what they say? Show me. I thought you said all of it.
Oh, I don't think
I do it in a time. It's like a nice that looks nice.
Honesty is always good.
I'd rather be honest with you. I'll try to say
But then everyone gets better.
It's a dog. She ran out. Like, why'd you run out in front of him? That's gonna scare
I did his turn.
Right across the road. Just bolts. Got it. And the first thing I do when I walk out, I'm trying to throw up, walk upstairs, like, back down. I'm like, give me a second. I go in and grab a like, the tires, not the tires.
I was gonna say the flag.
She walked up and was like, I don't know. I'm not going to take it apart. No, it's chilling. Clean out. Scrub. You know, just scrub it to make sure that was my 9-10 down there that I could see it. Completely dismantled. My car that needs to be operational. Spray painted. So if you see a great digger operate, you go and give her a hug. And you tell her, hey, Levi, let me know how much. Don't tell her how to manage the coach knows it.
All right, let's get started on part 2. Be able to wrap things up. Am I you guys' last block too? Oh yeah, perfect. That way you can go study. Okay. All right, so block 2, same terminal, core terminal objective. Now, just a reminder, we're still in the larynx. Okay, so masses of the larynx, vocal fold lesions or vocal cord lesions, same thing. Nodules, polyps, cysts, polypoid chorditis, contact ulcers, and granulomas, and then we'll talk about laryngeal leukoplakia and then squamous cell carcinoma. So vocal fold nodules are paired smooth lesions located on the vocal folds. So the only way we can, most common symptom is hoarseness, and the way we can diagnose these is through a laryngoscopy. We have to refer them out to ENT. First line treatment for these patients is going to be vocal rest. We can refer them to a speech therapist if that's necessary. And if it doesn't resolve, we can also refer them out for surgical excision. But it's a lot of risks that come with that, because if they're removing a nodule, it might cause some fibrosis or scarring of the vocal folds, which can also lead to dysphonia or abnormal phonation. So vocal fold polyp, so this is a unilateral mass on the vocal folds as part of, it develops on the lamina propria. And most common cause is vocal trauma. They can have some hemorrhage associated with it, that's with the trauma. And when we talk about trauma, thinking about intubation. So still having that foreign object inserted into the larynx, that's still considered trauma. Most common symptom is going to be hoarseness. Definitive diagnosis is still that laryngoscopy treatment. If it's small, we can prescribe corticosteroids or, allow them to rest and recuperate. If it's large, that's where it comes into play where we need to send them out to ENT for surgical excision. Now, vocal fold cyst, this is also, it can be unilateral or bilateral. So this is a mucus, a cyst, so fluid-filled cyst that develops from mucus secreting glands. True cyst and pseudocyst, difference is the epithelial capsule. Only way we can know is a laryngoscopy. I know, but that's the only way we really know. Most common symptom is hoarseness, and our definitive diagnosis will be using a laryngoscopy. Really just to identify if it's true or a pseudocyst, which comes into our treatment plan. If it's a pseudocyst, it can resolve with vocal rest. If it's a true cyst, it may never resolve, and they may have to get it excised. But again, that comes with risk. Surgical marsupialization, so that's just the process of removing that cyst from the vocal fold. The polypoid chorditis, so that's swelling of that gelatinous matrix of the vocal folds. That's also known as Reinke's or Rinke's edema. So basically that elastin in the vocal folds, elastin's role is to be resilient and allows tissue to expand and come back together. But if it's loosened, it remains expanded and does not have that rebound. Most common cause is going to be smoking, also can be caused from vocal trauma, chemical irritants, or hypothyroidism. Most common symptom, hoarseness. We're going to get our laryngoscopy, and then we have to treat the cause. So if it's secondary, if they're a smoker, we have to start them on some type of medication for tobacco cessation, remove the irritant. If it's due to hypothyroidism, we can treat them with levothyroxine, or we can also do a surgical resection. This is just a good picture and example of that polypoid chorditis. You can see the swelling there. Now getting into contact ulcers and granulomas. So essentially they're the same thing, just in different processes of healing. So the ulcer is initial trauma to the vocal fold. The granuloma is the process of healing, the skin regenerating. Just think about it like a scab developing. Causes vocal trauma, intubation. Chronic can be GERD or muscle tension dysphonia. Two good examples on the left, one of a granuloma, and then two on the right, that contact ulcer, and that's an intubation tube there. See that trauma. Symptoms, most common cause, hoarseness, some odynophagia, so that's painful swallowing. Definitive diagnosis, we still have to do that laryngoscopy. Treatment for these patients, we can start inhaled corticosteroids, may resolve spontaneously, but it's okay to go ahead and start that for acute and chronic. If they do have GERD, go ahead and start a PPI to treat GERD, because that could be the cause of a chronic ulcer or granuloma. Now getting into vocal fold paralysis, so you can see on these pictures here, on the left, it's what the vocal fold should be doing with respiration, with breathing. On the right, what the vocal fold should be doing with phonation. Normal is at the top, unilateral paralysis, like on the right, you can see where it has a smaller opening. And then that bilateral paralysis, it looks the same as if the patient is just breathing. It's just going to remain open because the vocal folds are not moving, they're paralyzed. This could be secondary to damage of that recurrent or superior laryngeal nerve. Remember, that's cranial nerve 10, the vagus nerve. It could be a lesion or impingement. Most common cause is idiopathic. This can randomly occur and then resolve. But if in the patient's history, they recently had a surgery, recently were hospitalized, perhaps they were intubated, if they had a thyroidectomy, so those nerves run very close to the thyroid, or a parathyroidectomy, that could be a cause. Any history of cancer or radiation therapy, and then that skull-based tumor or rheumatoid arthritis. Symptoms, they may have that breathy dysphonia, forceful voicing. Again, definitive diagnosis, they have to get in there and see how the vocal folds are moving, so they have to do a laryngoscopy. Treatment will be decided by ENT, whether or not they want to perform surgery, injections, or just observe. Now for bilateral, essentially it's the same thing, except instead of one vocal fold being paralyzed, it's two. Both causes are generally the same, that intubation, thyroid surgery, parathyroid surgery, esophageal cancer, and then also thinking about how close in relationship the esophagus is to the larynx. So if they have a cancer, if they have a tumor, it's pressing on that vagus nerve or the recurrent nerve, laryngeal branches of the vagus nerve. Symptoms, they could have biphasic stridor. Again, our definitive diagnosis is going to be a laryngoscopy, and we're going to refer to ENT for treatment. All right, first question. I said this like a million times. No violence. Why are you guys looking at me? Read the question.
What are the most common symptoms seen in patients with vocal cord nodules?
Horses. All right, next one.
45-year-old teacher presents question.
Go, Kyle, go.
Let's
45-year-old
go.
female teacher presents with a 3-month history of progressive hoarseness. She denies pain, dysphagia, or recent upper respiratory infections. She notes that her voice worsens after prolonged speaking. She's a non-smoker with no significant medical history. She was referred to ENT for a laryngoscopy. Her laryngoscopy examination revealed a unilateral smooth lesion on the lamina-propria portion of the right vocal cord. What is this patient's most likely diagnosis, given the presentation and laryngoscope findings?
What are we thinking? C. Yep, vocal cord contact ulcer. Not so much given the laryngoscopy results. Same thing with the cyst, and then that polypoid chorditis. We don't see the Wernicke's edema. Both vocal cord nodules are usually going to be bilateral. All right, next one.
A 36-year-old male singer presents with a 2-week history of progressive hoarseness. He denies pain, dysphagia, or recent upper respiratory infections. She is a smoker, otherwise no significant medical history. She denies recent surgeries or intubation. She was referred to ENT for a laryngoscopy. Her laryngoscopic examination revealed lesions on the arytenoid cartilage. What is the first-line pharmaceutical treatment for this patient's condition?
What is the patient's diagnosis? Oh, somebody said it. No. No. Nobody know? Nodules, potentially. Ulcers, granuloma. So what do we do for ulcers or granulomas? Steroids. Inhale corticosteroids. Ooh, that was hard. All right, laryngeal leukoplakia. Most common cause is going to be smoking or chronic GERD symptom, no change, hoarseness. We have to get a laryngoscopy to diagnose this. On laryngoscopy, we'll see that well-demarcated, non-ulcerative, thick and white plaque, and you can see that in that picture. Little change here, though. We can't diagnose based on, we can't get a definitive diagnosis based on the laryngoscopy. We have to do a biopsy because we don't know if it's just dysplastic cells or if it has developed into an early squamous cell carcinoma. So we will biopsy to get a definitive diagnosis. Treatment, if they are a smoker, stop smoking. If they do have chronic GERD, prescribe a PPI. It can cause some reversal if it has not developed into squamous cell carcinoma. So we'll refer them to ENT for close observation. And then complications is that same thing, developing into squamous cell carcinoma. That's what we want to prevent through treatment. And finally, squamous cell carcinoma. This is the most common cause or most common malignancy of the larynx. It typically presents in men ages 50 through 70. Most common cause is smoking. It can develop from human papillomavirus as well, because remember we talked about the recurrent respiratory papillomatosis. Symptoms, most common, hoarseness greater than 2 weeks. So we're out of that acute range. They can have some hemoptysis, some weight loss, or referred pain. So it may feel like they have pain in their ear, but it's really coming from a squamous cell carcinoma in the larynx because of that nerve innervation. Laboratory, so these are just some labs that we can consider. You may see some elevation or a decrease in or changes in white blood cells. Imaging, so getting an MRI of the neck to see if it's any masses causing their symptoms. And the biggest thing with squamous cell carcinoma of the neck is usually not the primary lesion. So if we do a biopsy and confirm that it's squamous cell carcinoma, we need to get a chest CT because that more than likely that is not where the cancer started. It probably started in the chest. So we have to get a chest CT to ensure or find the primary lesion. These are just some pictures of different stages of squamous cell carcinoma. Pretty obvious on a laryngoscopy, but we still need to do that biopsy for a definitive diagnosis, which will be referred to ENT. We just talked about that. So same thing for laryngeal leukoplakia and squamous cell carcinoma, biopsy. Treatment. So these patients, believe it or not, they do have a good prognosis if we catch the cancer early. So same thing. And when thinking about cancer, so whether it's laryngeal leukoplakia or if it's squamous cell carcinoma, so because remember laryngeal leukoplakia can develop into squamous cell carcinoma. So if we catch that early, we're preventing it. If it is early stage of squamous cell carcinoma in the larynx, we can still treat and prevent it from developing, or metastasizing. So they do have a good prognosis as long as it's detected early. Different options, radiation, surgery, chemotherapy, but we'll refer them to ENT and they'll coordinate with oncology.
62-year-old male presents to the primary care clinic with hoarseness. For the past 6 weeks, he reports random sharp pain in his ear and odynophagia. He denies any recent fever, upper respiratory infections, or vocal strain. His past medical history includes hypertension and type 2 diabetes mellitus. He denies alcohol use. He started smoking cigarettes 10 years ago, 40 packs per year. His physical exam is unremarkable. His laryngoscopy exam reveals a rough, irregular, ulcerative mass on the left vocal cord. What is the patient's most likely diagnosis given the clinical presentation?
What are we thinking? A squamous cell carcinoma. And last one.
54-year-old male female presents to the primary care clinic with persistent hoarseness for the past 2 months. It's a what? Sorry, I thought you said.
It was another question that I can change the pronouns.
She-
It went from a male to a female, and I was like, looks like that change pronouns.
She has a 50-pack per year smoking history and occasionally drinks alcohol. She denies throat pain or recent infections. On laryngoscope examination, a thickened white lesion is seen on the right vocal cord. The lesion is flat, non-ulcerated, and without hemorrhage. Which of the following is the next best step in evaluating this lesion?
Biopsy. Gotta see what is the deal. All right. Any questions? All right. I'll stay up here for a little bit if anybody has any additional questions. Good luck tomorrow.